patient usually lost vision acutely. These often came back, and it was very destructive to the patient's vision. Often, they'd be 2200 after the laser. Again, PDT is the cold laser. It stopped the growth of new blood vessels and did still have some applications. And I do have some patients I occasionally treat with PDT for specialized applications. It tends to lower the treatment burden, and it still does have some applications in practice, but much more limited. But again, 2005 was the advent of Avastin, Lucentis, and later Eylea, which was developed a little bit later. And these compounds are basically antibodies that are injected into the eye, either fragments of antibodies or antibodies that are designed to bind up VEGF. So VEGF is this vascular endothelial growth factor, and it's basically what lets those little vessels, those new vessels, that neovascularization grow into the retina. So basically, when you inject one of these compounds into the eye, it soaks up the VEGF that's in the eye, sort of starves those vessels to shrink, they stop bleeding, and hopefully preserve and improve someone's vision. And again, so I'm sure you all know somebody who's getting these injections, usually on a regular basis, at least initially. This treatment is a fantastic treatment, but it is not particularly a cure. There are some people who get 2 or 3 injections and being cured, but for the vast majority of people, this is a process of controlling the disease and minimizing the impact of the neovascular membrane. And again, we do this in the clinic. This is what I do half the day probably at this point. Is just we numb up people's eye, we clean it up with betadine, and we do an injection with the patient, kind of just sitting here back in the chair. And it's usually not particularly uncomfortable. It looks a lot worse, and I can trust me, the first time I have to explain it to somebody, I get all sorts of grimaces and looks of disapproval and saying, you're going to do what, where, huh? Yeah. So, but it's not bad, and I tell people once they get through the first one, most people don't have that much of an issue later on. This is probably a little more than we need to go into. This is kind of just a summary. So this was the example of how beneficial these treatments were when we first got them. So when we started, every treatment did nothing but slow down the rate of people's visual loss. When we first had, this is the Lucentis data here, when we first had this drug for the first time, we had 40% of our patients gaining 15 ETDRS letters. That basically means 3 lines of vision. And some were even gaining 30 lines of letters or 6 lines of vision. That was unheard of before the advent of these medications. And you can kind of see here, just in comparison, this was one of the clinical trials, Marino, which was a Lucentis injection trial, versus sham. Here, the people who didn't get injected lost 3 lines of vision. The ones that got injected usually gained more than 1 line of vision. So huge, significant change. And then when we looked at PDT, which was the standard of care before these drugs, again, people were losing vision with PDT, just not as fast. But again, with the drugs, these anti-VEGF drugs, they were doing much, much better. Okay. So there's a lot of new treatments on the horizon. There are people working on topical drops that you can put in the eye, or sorry, on the surface of the eye, anti-immune drugs that might help slow down the disease systemically, or even compounds that we can inject in the eye that maybe last for 3 months or 6 months or 12 months. Because as any of you know that might be undergoing injections, sometimes you may be going in every 4, 6, 8, 12 weeks, depending on the state of your disease. Okay. Does anybody have any questions at this point? Yes, ma'am. Mm-hmm. Yeah, that's your optic nerve, and I kind of glossed over that. So you can kind of see here. No, this is your optic nerve. That's not a great picture, but yeah. So this is your optic nerve, and that's the cord or the cable that feeds back to your brain. Okay, so that's the optic nerve, and it's always off to the side, and that's why you have a blind spot. Your blind spot is actually caused by your optic nerve because that's the one area of your retina that you can't really see through. Any other questions? Or? Yes, ma'am.
In the 3 diagrams you had of the early, intermediate, and advanced.
Yes, ma'am.
I just found out that I had it, and she said it was early, but she also told me it's very good. I wear more sunglasses.
Right.
More antioxidants.
Right. So that's kind of the difference between what you might hear from Yeah, I was okay. Fine. So what you might hear from your OD versus MD versus retina specialist. So according to the trial, people with intermediate and advanced or more intermediate benefited significantly from taking the ARED supplements. People with early, they really didn't see a statistically beneficial effect because they only followed the patients for 10 years. A lot of us, depending on what the patient sees or their family history or other issues, will go ahead and recommend the AREDs, but I don't say you have to take it. I say, look, in the study, if you have intermediate AMD, you should be on the vitamins. That is not a question. If you have early, it's somewhat questionable sort of how much benefit you're doing versus if you're one of the several hundred people that's going to take the vitamins to no effect. So I would say, I never recommend, I'm very agnostic about the brands and things like that. I tell them the studies show that this formula was what was used in the study, and we know that this is beneficial. So
disregard what you said.
no, I'm not saying that. I'm just saying that don't take something that says like eye health vitamin that you get over the internet for $40. It should have these 6 components. It should have these 6 components if it's an AREDS 2 vitamin. Now, you can take other supplements. I think that there's probably some benefit to some of the other things. But we know, according to the study, that this is what was helpful. Okay.
Would you say at this stage that somebody should graduate from the optometrist to go right on to a specialist?
Not necessarily. I think if you have early AMD, then you're probably, as long as I think you're fine seeing your optometrist or regular ophthalmologist. If they're not comfortable, usually they'll say, your disease is getting a little worse. Maybe you need to go see a retina specialist or something like that. Yes, sir. I have heard of it, but I'm not that familiar with it because I'm very, and this is sort of the difference between the OD, MD, retina specialist. I'm very much, I make the recommendations according to the studies. I don't try to sugarcoat it. If the studies supported it, I say this is the way I feel about it. If there's not good data to support it, but it seems like a good idea, I say that's okay. But, as I say, as long as it has this in it, you're fine. If they want to add something else, that's probably fine. Yes, ma'am.
My doctor said, like you said, maybe, you could take this.
Right.
Didn't really recommend it.
Right.
If I do take it, what about I take Centrum Silver? Do you take it along with it?
You can take it along with it I'm sorry. So the question was, if you're taking a multivitamin, a Centrum, some 1-a-day supplement, can you take the AREDS formula also? Answer is yes. So in the study, people were either allowed to take a multivitamin or not. There are not sufficient quantities of any of these components in your multivitamin to give you an adverse side effect. So it's completely safe to take your multivitamin plus the AREDS supplement. So, yes, sir. Sure. So the question was, what's the benefit of laser versus anti-VEGF treatment? So, and this kind of, I tried to allude to it here. Let me get to the right slide, sorry. So there are indications for laser where laser is still effective. I do use laser from time to time, but we almost never use it as a primary therapy, and this is why. So this was a trial where they compared an anti-VEGF drug, in this case Lucentis, which is like Avastin and like Eylea, very similar, and they compared it to cold laser, which is photodynamic therapy or PDT. And again, this was the standard of care from 2000 to 2005, and it did prevent the rate of visual loss. So you weren't as bad as if you got nothing, but clearly as primary therapy, anti-VEGF drugs are clearly superior for the majority of people. So as a first-line therapy, there's really no one that's doing PDT anymore. Now, there are some people with poor vision. They're getting multiple injections. They're not seeing well. They're not doing well. And sometimes in those cases, we'll pull out the PDT because it's you do the laser, it usually lasts 3 to 6 months, sometimes a long time. May not improve their vision very much, but it decreases the treatment burden. So if I have somebody that's terrible vision in one eye, pretty good vision in the other, they're kind of 2400, they're leaking, I inject them and they do okay, but it's really not improving their quality of life. I'll often say, look, maybe we should do the laser, see if it dries up the eye. It'll keep you from having to come in and having multiple injections over and over again, and will keep you at about the same baseline vision. But as a primary treatment, there really no one's doing PDT anymore. But like I said, it does have a role. Does that kind of explain the?
One other question. Are we making kind of linear progress or more geometric progress in this disease?
Well, I'd say in 2005 we made geometric progress. So the difference between 2004 and 2006 was huge. Okay, the difference between 2006 and 2013 is that we have drugs that last a little longer, like the Eylea, and that work a little better. So they penetrate the retina a little more. People don't need as frequent injections, and so it's kind of been incremental from now. And really, the next stage is sort of getting drugs that we can inject much less often. That's really kind of where it's going now. So that's more of a linear, improving your lifestyle, improving your quality of life versus the amount of vision. Now, there are some new compounds coming out that show even better visual results. There's clinical trials. There's this drug called Fovista. That's a compound drug. There's these things called DARPins. There's a number of sort of next generation things, but they're all going to be linear. They're linear improvements versus 2005, which is a huge, huge change. Yes, sir. Right. So I have a few slides. Let me cover them real quick because I think there's enough interest in the genetics and vitamins, and I don't want to go too long. But so let me try to cover your question a little bit more broadly because I think there's questions about vitamins and genetics. So AMD is one of the most well-worked out multifactorial diseases that there is. The genes that are AMD are very well understood. We understand most of the contribution of your genetics to the disease. The big two genes are ARMS and complement factor H, and I'll talk a little bit more about those. But basically, I can take a cheek swab, send it off to the lab, get the results in about a month and a half, and I can tell you what kind of risk you have. Okay, so they can do a logarithmic analysis of the genes you do have and the genes you don't have and kind of tell you which of these categories you fall into. And they actually don't do it this way anymore. This is kind of an old slide, but they basically stratify you as a very low-risk person, say, first quintile or whatever, or the high range. And if you're one of these people that comes into my clinic and I do, for whatever reason, choose to do the genetic testing and you come back as an MR5, I'm going to say, you need to take the supplements. I don't care whether you just have early disease. And that's why I say it's a little variable because I'm using my clinical judgment, not necessarily backed up by studies, to say that if you're a high-risk patient, then I'm going to do everything I can to slow down the progression. So if you come in and you say, well, I have family history, but I don't really see anything, I'll probably do the genetic testing if you have any early findings at all. And if you come back higher than average risk, then I'll say, you really should take the AREDS vitamins regardless of what our studies say, because it makes sense that we should start a little earlier because, again, this is a lifetime disease that damage is done over your lifetime. So anything that we can do to kind of bend the curve earlier is going to keep you out of trouble. So I think the genetic testing is important, and we're starting to do that more and more for different reasons. One is to stratify your risk factor, to tell you where to take vitamins. Another is actually to tell you which vitamins to take. So there's a lot of interest in the vitamins. So let me kind of touch on this a little bit, and then I'll answer any other questions if there are. But basically, the AREDS 1 study was published in 2001. And basically, they took groups. They did placebo, they did zinc, they did antioxidants, and they did antioxidants plus zinc. And what they found was the people who got antioxidants plus zinc did better. So they was like, okay, well, everybody's going to take antioxidants plus zinc if you're intermediate age-related macular degeneration or higher. The early group, they didn't see as much effect, but again, this is kind of it's hard to study a disease like this because it's over, your 80, 90, whatever years rather than just a 10-year window that they were looking at patients. So So this is kind of a running joke is that, so we thought that this antioxidants plus zinc was the best, so it was kind of the hammer. So we said, look, you got AMD, we're going to hammer it. So a good quote was, give a small boy a hammer and he will find everything he encounters needs pounding. Okay, I call in my house, this is the law of Nathaniel, who is right here with his Lolo here. But perhaps something more measured is actually more appropriate. So what we found is there's actually kind of a personalized medicine way to approach this. And there were some recent studies, part of Mass Pioneer, partly from a biotech company, a biotechnology company, looking at these two genes, this complement factor H and this ARMS2 gene, and kind of looking at how people with different genes responded to the different vitamins. And it's kind of a complicated topic, but basically, if you had this complement factor H, then taking the zinc actually made you worse. So if you took the regular AREDS2 vitamin, you got worse. If you had multiple copies of the ARMS2 gene and you took antioxidants, you actually got a little worse. So there may be patients in the general population that we're giving the AREDS2 vitamins to that we actually might be making them a little worse based on their genetics. But we didn't know any better, because when we did these studies, we didn't have the genetic basis or we didn't have the genomes of these people. What they actually went back is they had everyone's blood that was in this study. They went back and looked at the genetics and then looked at how they responded, and they kind of figured this out. And this is very new. I mean, this just came out about 2 months ago at a American Society of Retina Specialists meeting in Toronto. The big picture is this, without getting lost in the forest. If you're taking nothing for intermediate AMD, and then over 10 years, you have about a 41, 42, 43% chance of progressing. Okay. If you follow that AREDS2 study, or AREDS1, I should say, and you take the antioxidants plus zinc as a population whole, you bend that curve down to about 35%. So it's less, but it's not a huge effect. Versus if you take what's appropriate to your genetics, you actually only progress about 28%, 27% of the time. So it's a big difference. You know, that's a number of people who will never develop AMD because we went to the trouble to figure out the genetics and figure out which supplement was better for them. So the supplement thing has only gotten more and more complicated, and unfortunately, not only is it a medical issue, but there's all these patents and these biotech issues that kind of surround the sale of the vitamins, because this is a huge industry for Bausch & Lomb and these other companies, and now they're having to try to figure out how to incorporate this new information into what's better for a person. So do we just give AREDS2 to everybody, or do we talk about genetic testing the appropriate people? And who are the appropriate people to test? Just the people with intermediate or people with early? You know, if it was me, I would probably, if I had early, I'd probably do the genetic test and see what it said. If it told me just to take zinc, I'd probably just take zinc, even though I don't necessarily fall into the study categories because we just don't have guidelines for everything. And that's, you know, you all know your doctor always follows the medical guidelines, but there's always an element of art to medicine still, even though we do have very good clinical guidelines and data. So was that a little too far afield to answer the question? Or? Okay. Yes, ma'am.
Two actually, and they're not really related, but the first one is there are mom and aunt Betty.
I'm sorry, what?
Mom and aunt Betty.
Okay.
Mom they both had wet and dry one eye.
Okay.
Mom's, I don't remember what hers cost, but it was significantly less. Aunt Betty's was $5,000 per injection.
Right, right.
She had insurance through the government. Mom had Medicare.
Right.
The other question was, side effects are different.
Okay. So let me, yeah, I think those are both important topics, so let me try to cover both. Okay. And you could spend, and people do spend, days at meetings talking about that first question, okay? Because there's 3 drugs that we use: Avastin, Lucentis, and Eylea. Avastin is not FDA approved for wet macular degeneration. There's never been an FDA approved trial testing it. Clearly it works, okay? Lucentis is an FDA approved drug made by Genentech, who went through the FDA approval process, and all those slides of the data were from their phase 2 and 3 clinical trials. Eylea is similar to Lucentis. It is an FDA approved drug. It went through the approval process, phase 2, phase 3, you know, post-marketing approval, et cetera, made by a company called Regeneron. Okay? as you can imagine, this is a billion-dollar business for these drug companies. All the drugs seem to have, they all work, okay, to a certain degree. All right. The prices are extremely different. Avastin generally costs about $50 per injection. Lucentis retail, the drug costs about $1,900 per injection, and Eylea costs about $1,800 per injection. Okay. And I use all three for different reasons in different patients. The Avastin, we don't buy from the drug company. Okay. So we buy it from a compounding pharmacy. So I don't know if you use compounding pharmacies for any of your things, but basically we depend on Leiter's Pharmacy in Arizona, all these different little compounding pharmacies around the country, some of which are very sophisticated. I don't want you to think that this is somebody sitting under a hood in Ocala or whatever. I don't know what city to bash, but just putting things in a tube and licking their finger and shutting the vial or anything. So they actually buy the cancer drug Avastin from Genentech, and then they aliquot it, and they send it to us. Okay. And for some of my patients, that's the only choice because they can't afford it.
That's the one that translates to $5,000 an eye?
No, that's the one that's $50 an eye.
Oh.
Okay. So that's a cancer drug, but people saw early on that it worked pretty well in the eye. Yeah, so it's off-label. Actually, I was at Miami when we did that. Phil Rosenfeld was the father of Avastin, and we were injecting it in Miami before anybody else was. And so that's all I used during my residency. My patients, I had public health trust patients. They could not afford. Like, all my care was free, so we were using Avastin because it was our only choice. Okay. The issue with the compounding drugs is sterility. So if any of you know about the New England Compounding Pharmacy and all the mess there, the New England sterility, or the integrity of the drug. So, New England Compounding Pharmacy was an Avastin compounder. Many of you are familiar with all these cases of meningitis, patients dying, not from the Avastin, but from other drugs they were compounding. And because compounding pharmacies are kind of regulated, but kind of not really. And there's been several outbreaks throughout the country. There was a case in Hollywood, Florida, where there were 14 patients injected one day with compounded Avastin who all, basically were blinded by the drug because there was a contaminant. And, we were in the Bascom Palmer ER, and these patients came pouring in, and they were all in one person's clinic, good doctor, established doctor in Broward County, didn't do anything wrong. His technique was perfect. But all these patients lost their eye, and they're all obviously have a lawyer, and like the guy's done, as his career's done. So there are complicated medical legal issues with using the Avastin, because again we cannot purchase it and use it on label. So as a result, the drug companies that went through the approval process do package the drug, they do GMP or good manufacturing protocols, they distribute us the drug, and we use it when appropriate. Okay. So there's the sterility issue, and then there's the economics issue. So honestly, when I can, I try to use the Lucentis and the Eylea, but like I said, I have plenty of patients that are on Avastin, because when we're using Lucentis and Eylea, we're using it on label. There's also been some data, and I tend to use a little bit more Eylea than Lucentis, that the Lucentis and Eylea tend to produce fewer injections over time. So you actually decrease the patient's number of their treatment burden, and they tend to last a lot longer in the eye. So it's an enormous cost difference. I think part of how you perceive it is based on your politics. I hate to say it. I had a patient, very nicest lady in the world. She had came to me from somewhere in Michigan. She came in on Avastin, and she had 3 or 4 injections up in Michigan. Came in, saw me. I was like, "Oh, you're looking good. All right. Well, you've been treating you every 6 weeks. Okay, great. All right. Well, you look good. Well, stable." I treated her a couple times, stretched her interval out to about 8 weeks, maybe 8 or 9 weeks. She came in one day with a thing in her hand, just yelling at me, literally yelling at me, saying, "Why did you put this in my eye? This has blinded people, blah, 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 blah." And I had not really discussed the risks and benefits with her because, she was already in it from her other doctor. I kind of somewhat wrongly assumed that they had had that conversation and had made that choice. And so I switched her. Now, I've had other patients come in with the exact opposite. I'll have them on Lucentis or Eylea, and they're like, "Look, I think the other one probably works just as well. Let's try the other one because I don't want to, I don't want to personally bankrupt Medicare or, whatever they happen to argue, and they'll want to switch back. So, I try to be a little agnostic about it. I'll be honest, I tend to lean towards the ILEA because of the medical efficacy. But, it's a complicated decision, and I always ultimately try to explain it best I can. You can imagine trying to explain that in 3 minutes in an exam room, but it's complicated. It's medical, we're trying to do what's medically appropriate, economically appropriate, and then ultimately it's the patient's decision. No. So side effects, we think the side effect profile is pretty minimal. It's not the avastin that itself that has a side effect. It's just the contamination. Yeah. So the contamination is, that's just the processing of the drug. There was a slight tendency of increased thrombotic events in the avastin group when they looked at avastin versus Lucentis in the CAT trial, which is a large multi-center trial that was comparing Lucentis and avastin. So they saw a little bit more strokes and heart attacks in the avastin group versus Lucentis. And there's some scientific validity to that in that the Lucentis basically stays in the eye while the avastin gets processed out of the body and suppresses VEGF levels in the body. But it's not a huge safety signal, but there were definitely more adverse events, poor wound healing, some other things that happened in the avastin group that didn't happen in the Lucentis groups. It's complicated. Like it's hard to justify. Yes, sir. Mm-hmm. For macular degeneration, there's a couple things. You've probably seen these bionic eyes they've been talking about in the news. Those are mostly for people with retinitis pigmentosa. But there are some kind of electronic eye type things that are being developed. Nothing that's quite amazing yet, but there's some pretty significant prototypes that, when we look back 20 years from now, that'll be the Model T, and we'll be, driving the Honda Accord or Cadillac or whatever.
All right, I'd like to thank Dr. Parrott for coming today to give us some